Hi, welcome to Innovate Training. My name is Carol Pajot, and this is Miss Carol's Refresher Course. And we are covering medical billing right now. In fact, we are on Lesson 2. Last week, we did Lesson 1 about EOBs. Remember what EOBs stand for? Explanation of Benefits, or they're also called RAs. RAs are known as remittance advice. Now I want to apologize because last week I kept saying remission advice. I wonder if you caught that. It's remittance advice. So I apologize for that. RAs. So anyway, today what are we going to do? What I thought about doing today is before we go on into some heavier concepts or review some heavier concepts, I want to go over some main terms and concepts that we need to understand in order to provide a basis for what we're going to go further into. Especially next week, we're going to go over the CMS 1500 form. And we might have to take 2 weeks to do that. So, Medical Billing Refresher Course, Lesson 2. This is Medical Billing Terms and Concepts Review. Now, when I say the word review, I mean that most of you should have had some history with me or with the medical billing course or the field. Some of you may be new. That's okay. You'll still benefit from this because these terms are terms you will hear when your medical provider will be talking to you or your insurance provider will be talking to you about your coverage. Okay? So, regardless of who you are, you'll benefit from this lesson. All right. So, as a medical billing professional, you will be faced with many circumstances where you'll need to communicate with your patients or with your insurance carriers. So you'll need to understand some of these basic terms and concepts, especially when you're communicating with your patients. It's very important that you understand these terms and concepts so that you can explain it to the patient. If you're not sure yourself and you try to explain it, they're going to think, what's going on? Why is this person not sure? So you need to be able to make sure that you understand these so that you can talk to them with confidence. Okay? So I want to talk about the patient's out-of-pocket. What this means is, this is any money that the patient's going to be paying themselves out of pocket for the services, either for the services or for the insurance. And we're going to talk about the difference of that. There's 3 circumstances for which the patient is going to be paying out of pocket for the services, for services and procedures. And those are, number 1, the copay. And we talked a little bit about this last week, but I wanted to make sure that we go over it and that you understand it. The copay is a set amount that's paid at the time of service. It's usually associated with an office visit charge or with prescription coverage or emergency room. But it's usually an office visit. So when I say office visit, those of you who have experience billing, you'll understand that that means an evaluation and management code. Evaluation and management code is something we're going to talk about later when we go back into coding. But you should understand at least what evaluation and management means. If not, what it does mean is codes that are used to describe the time spent with the patient as opposed to a procedure. An example of that would be a 99213. A 99213 is a 3rd level office visit. About 15 minutes with a patient who's already established in the facility. Is not a new patient. Okay. There's 99211, which is 1 level, level 1, 99212, level 2. You kind of get the picture. Okay. So that's a copayment, a set amount paid out of pocket at the time of service. When I say set amount, it's always the same. So it's usually on the card or it can be found out by calling the number that's on their insurance card. But an example would be a $20 clinic for clinic office visits, maybe a $50 emergency room visit, $10 generic prescriptions, and $15 for brand name prescriptions. That's an example of a policy. They might have those type of copays that the patient will be required to pay. Now, these are always associated with managed care type plans. Managed care, HMOs or PPOs or POS. Okay, so copay. Coinsurance. Coinsurance is different. And you'll hear these terms used interchangeably, but that's incorrect, because copay is not a coinsurance, and a coinsurance is not a copay. Coinsurance is the amount that the patient pays that's based on a percentage of the covered cost. We talked a little bit about this last week. For instance, if it's an 80-20 plan, the insurance will pay 80%, the patient will pay the 20%. That's the patient's co-insurance. The plan could be 90-10, 60-35, 60-40, 65-35, 75-20. Those two numbers have to add up to 100. For an example, if the bill is $200, and for an 80-20 plan, the insurance will pay $160, and then the patient will be responsible for $40 of that. That's the patient's co-insurance. Deductible. Deductible is different from a co-insurance or a copay. This is an amount that must be paid out of pocket by the patient before the benefits begin. So, for instance, let's say they have a $500 deductible, and it starts in January. Usually it starts at the beginning of the year. At that first $500, the insurance doesn't even look at. They're saying that's not our responsibility. That first $500, go collect it from the patient. At that point, after that $500 has been referred over to the patient, then the insurance will start paying whatever percentage they pay at. So let's say, for instance, if they're Medicare, I think it's $141 a year, or $161, it may have gone up since then. $161, let's say, for instance, that first $161 gets referred to the patient. At that point, at $162, the Medicare will come in and start paying at 80%, and 20% will be the patient's. So there is where the problem is if the patient gets confused. You will need to explain to the patient that they have 161 or whatever it is their deductible is. That has to be met first. Then the insurance comes in and pays at 80%. That 20% is their responsibility. Or if they have a secondary, it'd be the secondary's responsibility. But if they don't have a secondary, then it's the patient's responsibility. Okay? So that's a deductible, a set amount that must be paid out of pocket before the benefits begin. Okay? Just like your car insurance. If you have a car insurance and you have a fender bender, car insurance has a $1,000 deductible, that first $1,000 has to be paid by you. Then the insurance will come in and pay whatever's left. Now, the last one is called a premium. Now, the premium is not paid to the provider. The premium is paid to the insurance carrier themselves. This is the amount that the subscriber pays periodically to carry the insurance, or to have the insurance coverage, in order to buy the insurance coverage. So if they pay $200 every month, $200 a month is paid so that they can have the coverage. Or let's say they pay quarterly. They may pay $1,200 quarterly for their insurance coverage. That would be their premium. That is not paid to the provider. The other three are paid to the provider because the provider is the one who's going to be doing the billing, and then those are paid to the provider, and then the insurance company comes in and pays as well. Okay, the next term I want you to get familiar with is called out-of-pocket max or maximum. What this is a part of your policy that limits the amount of out-of-pocket expense that you would have. This is to cover the patient in case of a catastrophic type event. Or when I say catastrophic insurance or catastrophic event in insurance terms is referred to an event that is so huge that it's life-changing, such as a car accident where you're in the hospital for a great deal of time, where it's going to be, you might have to put your house up, or you'll go into debt paying the bills. Another circumstance would be a premature infant. A premature infant is going to be in the infant version of the NCU. It's the NCU, neonatal unit, for weeks, maybe even months. So that's going to be quite expensive. So let's say, for instance, they have a 20% coinsurance. That 20% is going to rack up real quick with bills like that. So if they have an out-of-pocket maximum, that's a feature in their insurance that will cap a particular amount. So let's say, for instance, they have a lifetime maximum of $250,000. What that means is, in their lifetime or in an event, they reach $250,000 that they have paid out of pocket. The insurance will cap that and pay the rest. The patient won't be responsible for any more. But that's a provision that's written into a policy. So not everybody has that policy, so you need to make sure, if you are the insurer, or you insured, rather the subscriber, you want to make sure that that is in your policy. Or if you're the provider, you need to make sure that that is the patient's policy, and so you can explain it to the patient better. So that's called an out-of-pocket maximum. Exclusion. Exclusion is a term that's referred to anything such as an illness, injury, or a procedure that is not a covered service. It's usually because of a pre-existing condition, or it could be a service or procedure. We go back to the word catastrophic. Let's say, for instance, the patient only has major medical. A major medical plan is only for catastrophic or major events. It's not for routine care. So in that case, routine care would be an exclusion. Another term that you should be familiar with is called the birthday rule. The birthday rule is an informal type of coordination of benefits. Now let me explain what a coordination of benefit is. A coordination of benefits is just a term that refers to two insurances communicating with each other, coordinating to make sure that nobody pays, or that the patient or the provider doesn't get paid more than 100%. So, for instance, let's say the patient has two policies. The husband has a policy, the father has a policy, and the wife has a policy. Which policy, from their work, which policy do you bill as the primary? Well, with the birthday rule, you want to bill the person's insurance, the person whose birthday comes first in the year. That's the birthday rule. So if dad's birthday comes in February and mom's birthday comes in March, Dad's birthday gets billed as the primary. It doesn't matter what year they were born, it just matters what month in the year. Okay? So if they're both born on the same month, then you go by day. If they're both born on the same day, which would be rare, you go by year. If they're both born on the same day, month, and year, throw the policies up, and which one falls on the ground face up. I don't know. It really is an informal. It's not a set in stone rule. It's just one of those rules that you use when you don't know which one to do. Sometimes a patient or the subscriber, especially if they have kids and they have a husband and wife, will prefer one over the other. Say, hey, please use this one as the primary and this one as the secondary. That's fine. It's okay for the patient to try to get as much of their benefits as possible. That's fine. I have to tell you about a real quick case. We had twin boys. I worked in podiatry surgery. Both boys were getting both feet done, so that's 4 feet. Okay? I'm not done yet. Both boys had 2 sets of parents. Both boys had a mom and dad that were divorced and both remarried. So, mom and dad had insurance, and so did the stepmom and dad have insurance for both boys. By the way, did I say they were having all these surgeries at the same time? Okay, so here we are in the front desk. I've got insurance cards up the wang. Is that a bad word? It's not a bad word. I had an insurance card up to my eyeballs, and this stepmom saying, no, bill this one, no, this one, no, this one, no, for this boy, send this one as the primary, this one as the secondary. For this boy, this one is the primary. And I'm going, I didn't know about the birthday rule back then. If I'd known about the birthday rule, I would have said, you know what, when's your birthday? Okay. And just said, hey, that's a rule. Bye-bye. Bye-bye. It was a mess. And both boys getting both feet done at the same time. Post-op visits were a mess. And they were like 11 or 12. They were twins. Oh, did I say they were twins?
Yes.
Yeah, they were twins. Yeah. So yeah, it stuck in my memory.
Same procedure for both boys?
Same procedure. Same. Yes.
Oh my gosh.
Yes. They were identical twins, so they were both born with the same congenital issue, the flat feet. And so it was a major procedure. They had to have, with a flat foot, you have to have, a flat foot is the beginning of a bunion. And so the flat feet will start pulling this bone over. So we had to cut a bone, bring it over, and pin it. And in order to do that, you have to bring the metatarsal over and pin that. So, yeah. So, post-op visits, here they come, the moms and the dads, whichever, whether stepmoms or stepdads, I don't know, bringing them in the wheelchairs, and there they are, and yeah. And those of you who had surgery on your feet know that it's a big deal, 1 foot. Imagine having it done on both feet at the same time. Yeah. It's quite traumatic because you can't walk. You don't have a good foot to walk on. So you're in a wheelchair. Okay, birthday rule. And I just mentioned coordination of benefits. That's another term. Coordination of benefits was used to prevent overinsurance. So imagine those boys, we billed all of them at 80%. Somebody's going to get overpaid. So one gets billed at 80%, one gets billed at 20%. Primary, secondary. It ensures that benefits are never paid more than 100%. I'll tell you the other story about the guy with the Medicare and who had a whole bunch of secondaries, and this is before coordination of benefits, and he would have constant surgeries on it and then collect the secondary payments himself. So basically he's mutilating his feet for money. Yeah, I caught on that was happening.
Wow.
And his foot was a mangled mess. I'm not mentioning any names, so I'm not breaking HIPAA.
I know that.
All right. Coordination of benefits. So that's to make sure that nobody gets paid, especially the patient or the provider, more than 100% of what the charges are. All right. Medical necessity is another term. Medical necessity ensures that medical services are not paid unless the services are necessary for the condition of the patient. Like the guy with the Medicare. He didn't have medical necessity. Every time he came in and he wanted surgery, for some reason he got it. And I'm not talking on, that's all I'm saying. Anyway, it meets the standards of good medical practice, and it's having the right diagnosis to justify the procedures and the services rendered. Okay? If you don't have the diagnosis to justify it, then they should not be rendered. If we don't have medical necessity and we're billing the patient's insurance, it's very possible that they could deny it, and we would have to either write it off or even bill the patient. And when we get to Medicare, I'll explain how we deal with that. All right, participating and non-participating. These are two terms that refer to if a provider is contracted with the insurance carrier or not. A par or non-par, we call them. Participating, par, or non-par, non-participating. Meaning that non-participating, they're not contracted. They can still bill, but they won't get as much reimbursement, or rather, the provider will get the same amount of reimbursement. The patient will have to be paid more out of pocket. So it's very important that the patient understand if you are participating with that insurance or if you're not. For Medi-Cal, you cannot bill Medi-Cal unless you're participating. But Medicare you can, and we'll get to Medicare. We'll talk about that a little bit later. All right, next term, encounter form. This is a multi-purpose form used by most medical practices. It's also known as a Superbill, a charge slip, or Superbill, or encounter form. It's where the patient's name and date is written on there. The services are checked off. It has CPT codes as well as the ICD-10 codes, and it's a form that is used. The reason why it's called a Superbill, it's used by the patient if the patient is billing the insurance for reimbursement themselves. So the patient pays the provider, and then the patient bills the insurance to get reimbursed. Usually if we're not participating and we don't accept assignment, usually the patient will do that. Okay. All right, clearinghouse. We talked a little bit about this last week. It's a company or an entity that receives the claims for the provider and bundles them and then submits them to the various payers. It edits the claims for errors. Claims can then be corrected and resent, just like we talked about last week. And you only have to get one contract with that clearinghouse. The clearinghouse has to go and get the contracts with various providers, or various carriers. It makes it a lot easier for you. And it usually costs, well, back then it was like 35 cents. It's probably about 60 cents now, a claim. About as much as postage. All right. Tracking claims is another term. Once claims are submitted, the practice needs to keep track of them. What claims were submitted when? Your software should do that for you. Your practice management software. In the old days, and you might see some textbooks that still say, oh, you need to get an insurance log and write down every claim you send out. No. You'd have to hire somebody to do that. Your practice management software keeps track of that. You can run a report the next day. That report will tell you what claims went out when. Okay? Follow up on claims. 2 weeks for electronic claims. 4 to 6 weeks for paper claims. All right. So in summary, the terms and concepts that we reviewed today will help you better process the claims, better communicate with patients, and better communicate with the insurance carrier yourself. Next week, we're going to start the CMS 1500 form. So get a pencil. You're going to need a good, nice, sharp pencil. I would suggest using that. And this is Miss Carol Pajot from Innovate Training, and I'll see you next week. Bye-bye. Hi, this is Carol Pajot, and don't forget to subscribe, to like, and to hit that bell.